you know where's the pyloric sphincter, right? If the pyloric sphincter hypertrophies, okay, it's usually hypertrophy of the pyloric sphincter. Hypertrophy of the pyloric sphincter. You know that it normally shouldn't be hypertrophied. Anytime a muscle is hypertrophied, it means it's stronger. It means it stays closed longer if it's sphincter. See, the purpose of pyloric sphincter is to stay closed, not to stay open. Its purpose is to stay closed. Why? To allow enough time for gastric food to get digested and then let it pass through. The pyloric sphincter should be opening every 45 minutes on average, but again, it varies. Every human being's physiology and eating habits are different. Overall, once you eat food, it should stay there for, roughly speaking, about 40 minutes or something. Okay? And then it's passed on beyond that once it's digested. So the sphincter should not be open 24/7. It should be most of the time closed unless there's food to pass through. It shouldn't open. Now, if it's hypertrophied, that means it is most of the time closed, beyond normal. Even if when it opens, it doesn't open properly. So hypertrophied sphincter, it fails to open properly or completely. That's the basic idea. Hypertrophied sphincter. So this disease should be called hypertrophic pyloric stenosis. You can call it congenital hypertrophic pyloric stenosis because children are born with it. No, they're born with it. Okay. So now look, the sphincter should stay tight, closed. When it starts to open, even if it comes in contact with food, it does not open completely. It opens partially. Good? All right, so that's the first thing. Now, who's at risk? Boys. Firstborn. What is it?
When you say boys, I think the accident.
No, this is actually multifactorial. Okay? So boys are affected more than girls, and firstborn more than secondborn, thirdborn, and fourthborn. Okay. All right. Usually, it becomes symptomatic during the first week or after the end of first week. Okay. Now, let's say you feed the baby. So after feeding, they will vomit. And this vomiting is projectile. Projectile. Meaning when they vomit, projectile motion, if you learned in your high school, is a rainbow type of curve. So they vomit far. It's not just like they regurgitate and just drops on their clothing. They shoot. Okay, so that means there's enough force. Okay. Projectile vomiting after feeding. Usually it becomes symptomatic after the first week. 7 day, 8 day, usually. But again, it depends, right? Okay. Second thing is you should be able to feel or palpate abdominal mass. Size of the thumb, small mass, grape size, olive size, or let's see what else can we think of, M&M size, small mass. And this mass is usually in the epigastric region. Epigastric region, okay? Epigastric region. All right, and now be medial epigastric, not lateral. Medial epigastric region, okay? Just above your navel, about 4 or 5 fingers in that region, okay? That's where you'll feel this. Or about 2 fingers below the xiphoid process. Abdominal mass that you can palpate. Now this mass you can palpate. You can palpate with your own fingers on the baby's tummy. So when you're feeling the baby's abdomen, you'll feel this mass. Small mass, rigid, rough, rubbery mass. But it's smooth. It's not rough. Did I say rough? Sorry, smooth. Smooth, round mass. Smooth, round mass. That you can feel it. It's smooth and round. And it's rigid though. Okay. Now, that's the most important thing. There's nothing else to it. So, all the issue are due to vomiting. What does vomiting cause? Dehydration. And that's what usually it's devastating for children. Dehydration. What else? Hypochlorhydria. Okay? So, hypochlorhydria. That means your stomach acid decreases. As a result, it leads to metabolic alkalosis. Okay? Because of vomiting. Your plasma chloride and hydrogen decreases. Okay? Now, of course, see, in children, the acidity is not to the level of adults, so it's not putting them at risk of Mallory-Weiss tears or Boerhaave or anything like that, or esophagitis, so you should ignore that. Okay, that's usually, in children, it is very unlikely, because the acid is not as much as we can produce, okay? Okay, so again, nothing more than vomiting in a mass, okay? In a newborn, boys. But complication, dehydration, hypochlorhydria, and metabolic alkalosis. Done. There's nothing else to it. Now, when you do an exam, so this area will be narrow. You can do barium. Barium is the test of choice. You will see the duodenum is dilated and the stomach is dilated. Okay. So usually you can see something known as double bubble. Okay, you will see double bubble, two bubbles, one the stomach, one the duodenum. So let me see if I can do it the right way. Let's say this is the CT scan. This is the CT scan, and here, when you use barium, barium should actually have glow, and you will see stomach. So this is stomach, and then the duodenum, and here's the pyloric sphincter. So you will see one bubble, two bubble, double bubble, which is also with duodenal atresia, but you will see it here too. Okay. Yeah.
The sphincter before they do that.
Huh?
The sphincter before they do that.
Oh, sorry. Yeah, the antrum. Antrum. My bad. Yeah. Ooh. Antrum.
So is dilation of the antrum and the stomach?
Stomach is already dilated, so you will always see it because food is not passing through it. Rather than collapse, the stomach will be expanded because there's food there. But also now there's obstruction is here, so this area gets dilated too.
The antrum, not the duodenum.
Yeah. Okay. Okay. Now, what are you going to do about it? Well, you have to do sphincterotomy. You can carve it, the inside of the sphincter, to make more room, shave it off, or you can do actually cut it off too. So it depends how severe it is.
Balloon.
You can do that too. Okay, balloon dilation. You can insert a balloon there to dilate it, but it's not effective. You know, you might have to eventually just carve it on the inside. Okay.
Do Botox. Botox.
For children, no, it's not recommended. But again, so depending on the size of the sphincter, how severe it is. Okay. Again, essentially the solution is what? Surgery. Okay.
This can be done endoscopically, right?
Yeah, of course. All right. So that was anything else with stomach? Gastroschisis. And gastroparesis. Two more, right? I think that's it. After this, we go to pancreas, right? And what time is it?
10:14.
10:14? Okay, we have good enough time to do some pancreas. Gastroparesis. Paresis means partial. Yeah. Huh? Omphaloceal, yeah, will reach the abdomen. It's mostly the small intestine will reach there. Okay? Yeah. Well, we can leave gastroschisis for that too, but it's okay. Because the name, that's why I keep it here. Huh? Yeah, we'll do that in the pancreas. Okay, gastroparesis. And let's just say gastroparesis, and you know the reason I put gastroschisis, gastroparesis, they sound the same, but it's not exactly the same thing. Just because they sound the same, that's why I put it together. Gastroparesis. Paresis means partial paralysis. Okay, paralysis is complete lack of movement. Paresis, partial lack of movement or contraction. When we talk about muscles, you know muscles, you can call them weak muscle. You can call them paresis. And you can call it paralysis. Weak, the muscle does not contract so good. The contraction is weak. At the end of the day, you're not getting enough movement out of it. It's weak. Paresis is partial paralysis, partial lack of movement, or partial decrease in movement. Paralysis, complete lack of movement. So paralysis is severe form of movement. There's no movement at all. Okay, paresis is partial. All right, so when you say gastroparesis, It means the stomach is not able to contract properly. Okay, now one thing could be it's stomach muscle that's damaged, right? For example, we can think of scleroderma or Crest syndrome. Crest is more related to esophagus, limited to esophagus. Scleroderma can affect the stomach as well. So in scleroderma, let's put here scleroderma, which is not a common cause, but I'll leave it here for now. Scleroderma means it is smooth muscle fibrosis. Fibrosis of the circular, longitudinal, or oblique muscles of the stomach. At the end of the day, the muscle stomach is not able to contract properly. If it's not contracting properly, what happens? It's not able to churn and push food out of the stomach. So what happens to the stomach emptying? It's delayed. Okay, the stomach emptying is delayed. So the stomach will feel full most of the time. And that can put you at risk of Gerd, nausea, vomiting, and discomfort, this feeling of fullness and not a good feeling. Okay, so scleroderma. Scleroderma can cause gastroparesis because of muscle problems, gastric muscle. So that's one thing. Now, also, what if the nerve supply to the stomach is damaged? That's another issue. Okay, so now Muhammad said diabetes, and he's correct. So diabetes, but you know what I will do? I'd rather put here peripheral neuropathy. Okay, peripheral neuropathy. So you understand the term peripheral neuropathy. What does peripheral mean? Not CNS, right? Or peripheral nerves. Neuropathy means? Neuro means? Nerve. Pathy means disease. So disease of the peripheral nervous system, that's peripheral neuropathy. Now the most common cause of peripheral neuropathy in this country is diabetes. Okay, so when you think of gastroparesis, you're always going to think of diabetes. Okay, as a result, now the stomach does not empty fast enough. So delayed emptying. That's one thing. It also means abdominal distension. Especially the gastric area will be more distended. And it gives the feeling of being full. Not necessarily early satiety. It is long-term satiety. Okay? All right. Now when there's food, when there's too much food in your stomach and it's not being emptied, it can lead to, of course, LES defect. So this can put you at risk of complication. It would be Gerd. Gerd. It can increase the acid reflux. Okay, increase acid reflux. Not only acid reflux is increased because the stomach is full, but also the LES is incompetent and it becomes incompetent, it's slightly weak, stays open longer than before. Okay, that's it. There's nothing else to it. There's nothing else to it. So that's as long as you focus on this side. But then there's a medication that increases gastric motility. You can use that. So you will use a medication. So the solution is to increase gastric motility or gastric movement or contraction. Starts with M. Metoclopramide. Very good. So you can use that medication. Metoclopramide. Okay, metoclopramide. At the end of the day, I mean, diabetes, peripheral neuropathy and diabetes can do the same thing to bladder, guys. The bladder might not be able to empty, and you will have overflow incontinence. Okay, so diabetes can affect anywhere. So stomach is the latest version, but most bladder is first. Legs are first. But just know that diabetes is overall the most common cause. Okay. Yeah. Yeah. Dopamine antagonist. Sorry, dopamine agonist, yeah. Acts on the dopamine receptors. Dopamine. Okay, gastroschisis. You see the name is very similar, but it has nothing to do with stomach. It is when the abdominal content, which includes intestine, liver, stomach, all abdominal contents, go out of the abdominal area, which means there is a wall defect in the abdominal wall. Okay, and this the defect should be peri-umbilical. not in the center. So if this is the umbilical area, so that means a defect here or here, and suddenly you will have intestine leaking out or coming out, liver, including stomach. So I'll discuss this more when we talk about physiological hernia or omphalocele. Okay, it will make more sense there. But just so you know the name, gastroschisis means that abdominal content protrudes out of the abdominal cavity because there's a defect in your wall. Abdominal, there's a gap, there's a hole.
But it's still below the skin.
No, omphalocele is below the skin. This is actually out.
So this is complete outside of the body. So this is a congenital.
Omphalocele has the skill, as the skin, not the scale. Okay. Yeah.
Why would it be called herniation? Or why would it be described as herniation?
I don't. Let me use this ear because they're flipping the page at the same time. Honestly, I'm trying to listen.
Why wouldn't it be called or referred to as herniation?
It is hernia.
Oh,
Yeah, it is hernia. Yeah. Okay, let's move on to something else now. The pancreas. Okay, the pancreas. Okay, so number one, you should know the pancreas. Where is it located? Pancreas has the head, body, tail, and how about this area? Neck. What is the name for neck? One name is cervix, but in this case you won't use it. What's another name for neck? Isthmus. You can use isthmus. What else can you use? Acinar. You can use acinus too. Okay. So the neck area is just this area. You see this area. This is the neck area. So that's one thing about pancreas. Now, let's talk about structure related to pancreas. What is medial to the pancreas? Something that surrounds it like this. Duodenum. Good. Duodenum. The head of the pancreas related to what? Duodenum. The head of the pancreas related to duodenum. Head of the pancreas is related to? Whoa. There is a leak. I thought there was no leak, but I guess there is. Okay, so head of the pancreas is related to duodenum. Okay, let's use this. There you go. I want to use different colors because I want to use this. Wow. Now, how about the tail of pancreas? Spleen. Anything else? Stomach. Yeah. Okay. Very good. So spleen. Okay, so spleen. And then, of course, behind the spleen should be kidney. Okay. So, I mean, I did it wrong, but it should be a little bit backward. Just the tail is too long for whatever reason. So the tail of the pancreas is related to the spleen and kidney. Okay. How about the body? Stomach is in front of the?
Transverse colon.
Very good. So transverse colon is inferior. Good job. Transverse colon or the part of duodenum. So the rest of the duodenum, okay? The rest of the duodenum will continue here like this. Okay, it will go. You got the idea. Can't change colors. Okay. Now there's one major artery that goes on the superior border of pancreas. Splenic artery. That'll go to spleen like this. Splenic artery. Make sure you understand that one. Okay. You see this area, the neck? There's a major artery that comes out of this area. It's behind the pancreas like this. So if I think about it, so This artery also has a vein next to it. And then a purple vein as well. Okay, so what I'm going to do is use pancreas, what color? Yellow? Yellow, there you go. So actually this area, the neck of the pancreas, goes around it, so that means yeah, there you go, that's better. So these arteries come out of here and in front of the lower lobe, of the pancreas. Where is it here? Like this. It will go like that, and the red one, and then the pink one. So it goes behind the body, but in front of this lower lobe. Okay? Can you tell me the name of these arteries? Superior mesenteric artery. And how about the vein? Superior mesenteric vein. And how about this one? Portal vein. Okay? Very good.
Doesn't the superior mesenteric artery go to the right side?
Huh? Superior. Yeah, superior. Celiac trunk should be just here, so that's superior mesenteric. Inferior is much lower. It's not related to pancreas. Yeah.
Shouldn't the superior mesenteric be going towards the right side?
I mean, in my angle I have it, but let me just do it this way. So it really doesn't matter, but it comes. The issue here is it related to it? Yeah. So in my angle, if I did it that way, it doesn't really make a difference. It's slightly actually towards the left, not to the right. So let's do this.
I thought the inferior was left and the superior was right.
Okay, so where is it? Here you go. So it comes in this angle, but it makes no difference. And then you have the vein. Okay? All right. Now remember this, the splenic vein goes behind, the pancreas, okay? It goes behind the pancreas. And it combines with the superior mesenteric vein. And then it will make the portal vein, okay? So superior mesenteric, inferior mesenteric, and splenic vein, they will all combine to make portal vein. So the portal vein will develop just under the duodenum. And it will go behind the duodenum. So before that, again, so in some cases, if the pancreas is slightly up, you will see the portal vein coming out of there, but no. In other cases, no. Okay. Huh? Yeah, so superior mesenteric vein and splenic vein will combine together to make portal vein. Okay? Okay. Now, of course, the duodenum goes in front of these things, so I want to make sure that too. Duodenum. You see the superior mesenteric artery can compress what? The duodenum. I guess when we reach the duodenum, we'll talk about it, but for now, just know we're talking about the pancreas. So now, the relation of pancreas. Number one, it is behind the pancreas is nothing more than abdominal wall or back wall. In front of the duodenum will be stomach, which I don't have in this picture. In front of it is the stomach. Okay. Superior to the pancreas, what do you have? Splenic artery. Okay. And then around the head you have the duodenum. First part, second part, and third part. Okay. Now, duodenum we haven't talked about it. This horizontal area is 1, the vertical is number 2, and the bottom horizontal is 3, and in the distal part is the 4th part of duodenum. Okay. Inferior to the duodenum, around the neck, you have superior mesenteric artery and vein. Okay. Posterior to it, you should have splenic vein. And then lateral to it, you have spleen and left kidney. Okay. So know the relationship of pancreas when it comes to these structures. Okay. Between the pancreas and stomach, you should have the greater omentum. Very good. Or the greater omental sac, sorry. The greater omental sac. Okay. Okay, so that's in terms of gross anatomy, you should know. And then, pancreas, its blood supply is what? Oh, I should have done that. Very good. Let me just do this. Let's talk about the blood supply of, can't go more further than that. Blood supply of the pancreas. The body and tail is by which one? Splenic. That's clear cut, right? Easy to understand. And you might have the left gastroepiploic artery, which goes around the greater curvature of the stomach, might give you some branches. Okay, some branches. Now, the head of the pancreas blood supply. Remember here was gastroduodenal artery, which was a branch of hepatic, and which was a branch of celiac trunk, right? So celiac trunk, common hepatic, and then hepatic, and this is gastroduodenal. Gastroduodenal will come in behind, it will give you the right gastroepiploic, right? Gives the right gastroepiploic like this. But it will give you a branch that goes to duodenum. So this will supply, this is known as superior pancreatico-duodenal artery or superior pancreatic artery. So superior pancreatic artery or superior pancreatic head artery is a branch of what? Gastroduodenal. Gastroduodenal. Okay? Now, what is this artery right here? Superior mesenteric artery. It gives you a branch that supplies the inferior pancreatic artery. Okay, so the inferior part of the head of the pancreas is supplied by what? Superior mesenteric. The upper half of the head is supplied by what? Celiac trunk. So pancreas, the head of the pancreas is supplied by two arteries, celiac trunk and superior mesenteric artery. Okay? Let me see if I can make it a little bit clear. No, we'll just do this. We'll just do this. Why am I struggling? This was the pancreas. Uh-oh. There you go. So that's the pancreas. Now let's do its blood supply. So here you have the celiac trunk. The celiac trunk gives you a branch known as gastroduodenal. It'll give you a branch to the superior part of the head of the pancreas, superior pancreatic artery. And then you have, here you have superior mesenteric. And it gives you a branch to the bottom part of the head of the pancreas, so inferior pancreatic artery. Okay? Superior pancreatico-duodenal artery, inferior pancreatico-duodenal artery. So this is inferior and one is superior. So number one is a branch of celiac trunk. And this is a branch of superior mesenteric artery. Okay? Okay. Now, the rest of the pancreas is supplied by splenic artery. Okay, so the tail and head and body is supplied by splenic artery. So know these arteries, okay? Blood supply to pancreas. Let's go into histology of pancreas. What is this? Background, blah, 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 I don't know. Okay. Let's go to histology of pancreas. This is a big pancreas, good, okay? Now, pancreas will have these areas known as islets. They look like island. And what do islands look like when you look from plane? What color, usually? Water is blue, right? So let's make the pancreas blue. There you go. So what do islands look like? What color? Pale yellow color. Okay, good. So they will have these areas. These are known. Now we're talking about histology of the pancreas. We're done with anatomy. Okay, so these areas are known as islets of Langerhans. Islets of Langerhans. Okay, so islets of Langerhans. They're cluster of cells. Clusters of cells. Clusters of cells. Okay, so clusters of cells. These are clusters of cells. These are clusters of cells known as islets of Langerhans. Okay. Langerhans. Okay, so these islets of Langerhans. Now, these clusters of cells are made of three types of cells. Of course, if it's a cluster of cells, it's made of three types of cells. Let's say one is red. So that's not red. Okay, brown. That's fine. And then let's say green. And let's say now really pink. So all these cells will have three types of cells. So it's a cluster of cells. Just make it dark blue. Okay, so it's made of three types of cells. Now these islets are endocrine in nature. They're endocrine cells. There are endocrine cells. The islets are not exocrine. They're endocrine cells. You know, pancreas is one of the few tissues which is endocrine and exocrine at the same time. Okay? All right. Let's say pink. So that's 3 times. You okay? The way you said it, like you're suffering. Mm-hmm. Okay. So let's say pink is alpha cells. They're known as alpha cells. And let's say green is known as beta cells. And how about the blue one? Huh? Yeah.
I gotta go through the old alphabet.
Yeah. Delta cells. Okay? So that's the name of these cells. You find 3 types of cells, you give them 3 names, just to differentiate them. Okay? Just to differentiate them. Again, these clusters of endocrine cells are known as what? Islets of Langerhans. And they are made of 3 types of cells: alpha, beta, and delta cells. Alpha cells produce glucagon, which we have discussed before. Beta cells produce insulin. And then delta cells, soma. What is soma wrestler? Somatostatin. Somatostatin. Okay. And you know the function of each, so I don't have to go over them. Okay. Hopefully I finished GI a little bit early so we can go back into metabolism one more time. Okay. Okay, so that's for this. The rest of blue, the rest of the pancreas, which is the light blue, is known as exocrine pancreas. It's known as exocrine pancreas. Endocrine pancreas, or endocrine tissue, is rich with blood supply. They have a lot of blood supply. Okay. I think I can erase. Okay, so the exocrine cells are known as acinar cells. They're known as exocrine cells or acinar cells. You can call them exocrine cells if you wish. Or acinar cells. Okay, and let's see. Orange, there you go. You can use orange. So there's a bunch of these cells. Oh, that comes to the same color, but forget it. So all these cells will make glands. I mean, the rest of it, all these cells. Guess what? All of these cells, they form ducts. So they'll be connected. Let's see, how would I do that? So they will have these ducts. So there's one major pancreatic duct. There's a major pancreatic duct. So all these cells connect to through a duct. Okay. So these cells will connect to the main pancreatic duct through a duct. Okay. Whereas the endocrine cells, they don't have ducts. Endocrine cells are ductless. Exocrine cells have ducts. Duct is a small tube. I mean, why would you need tubes if you release things directly into blood, right? So the difference between exocrine cells and endocrine cell is endocrine cells have ducts, which is supposed to carry the solution nearby, but blood goes far away. So endocrine cells will secrete stuff into blood directly, so it can be carried all over the body. Okay. Okay. And endocrine cells always produce hormones. Glucagon is a hormone. Insulin is a hormone. Somatostatin is a hormone. So endocrine cells only produce hormone or secrete hormone. Exocrine cells, their product would be enzymes. Their product is enzyme. Enzymes and bicarbonate. Or so let's not say bicarbonate. Let's say, what would be another name? Buffer. There you go. Buffer. You can say buffer, yeah. I thought I had another name in my head, but that's okay. So let's just say bicarbonate. You know, bicarbonate and enzymes. Okay? And I'll tell you the enzymes. Are we good with this? Okay, so I'm gonna erase it now. Whoa. You go away. You go away. You are gone. Okay. So the enzyme, they're known as pancreatic enzymes. They're known as pancreatic enzymes. Now there should be protease. One group of enzyme is known as protease. Another group is known as lipase. Another group is known as amylase. And another group is known as nuclease or DNase or so forth, okay? Now, protease is any enzyme that breaks down protein. Protease is any enzyme group that breaks down protein. Lipase is any enzyme that breaks down lipids. Amylase breaks down sugar. Nuclease breaks down DNA or RNA or nucleic acid. Okay. The proteases that are produced by the pancreas are known as trypsinogen. Okay. Whenever you hear the term gen, what does it mean? Zymogen, inactive form of enzyme, right? Okay. So trypsinogen. They also produce chymo. What is chyme? Bile, huh?
It's what's mixed in the stomach.
Okay, food mixed with solution. That's what a food bolus is chyme. Yeah, it doesn't have to be bile. So chymo. Oh, I'm missing an O. Okay, chymotrypsin. Chymotrypsin. Well, yeah. So I'm giving the name of proteases. Chymotrypsin. One more is known as carboxy peptidase. Okay. You can also call them endopeptidase. Some of them that breaks down within the peptide. Endopeptidase. You can also call another group known as exopeptidase. They cleave from the end of a peptide. Exopeptidase. Do you remember when you talk about endonuclease and exonuclease? What was the difference?
Inside and inside and one's outside.
What is the end product of exonuclease?
Fragments. No, tiny
X nucleus.
Nucleotides only, single nucleotides. What was the product of endonuclease?
fragments.
Fragments of DNA. So what do you think is the product of endopeptidase? Peptides. Peptides. Yeah, which is fragment. You're right. What is the product of exopeptidase?
Amino acids.
Single amino acids. Okay, single amino acid. Okay, so those are, now lipase are just, now the enzyme group in lipase could be phospholipase. You see, you don't memorize, you just, once you have knowledge, you can make your own conclusion. Nobody has to even teach you. So phospholipase, good. What else? Cholesterol esterase. If you know the type of lipids, you can make your own conclusions. Okay. You can have triglycerides. Okay. Now amylase, they're just known as amylase. They only make polysaccharides into breaking down to single disaccharide, trisaccharide, something. Nuclease can be exonuclease or endonuclease or so forth. Okay. So these are some enzymes that you should know. Okay. Okay, and then the buffer is bicarbonate. So what are the products of pancreas? Well, one is pancreatic juice.
Enzyme and bicarbonate.
Yeah, one is pancreatic juice. Excellent. The pancreatic juice is enzymes mixed in what? Bicarbonate. And then you have pancreatic hormones, which is glucagon, insulin, and somatostatin. I don't think it's difficult, so you should be okay. All right. Let me eat one of brain stimulator. What is this? I'm eating brain. Do you guys know this? Dried brain.
Penis?
Walnut. There you go. That's good for your brain.
Dried brain.
It looks like a brain, right?
Yeah.
My grandma always told me, this will make you smart, this will make you smart. Now I know why she said, because it looks like a brain. She might have seen a brain somewhere, I don't know how. She was not educated.
Doesn't help.
It does. Believe it or not, it has the same lipids as sphingolipids.
Remember.
Mm-hmm.
We eat that every day.
It's good. Okay. Now, are we good so far? Okay. So would you remember this? Let's take a break and we'll go over physiology of the pancreas and duodenum together.